Hello, I'm Albert Wu, one of the investigators on the Proteus Consortium, and I have the privilege of presenting this reader's guide to using an article on patient-reported outcomes, or PROs. I'm an internist and healthcare researcher and professor of health policy and management, as well as epidemiology, international health, medicine, surgery, and business in the Johns Hopkins Bloomberg School of Public Health and School of Medicine. I also direct the Center for Health Services and Outcomes Research. We appreciate your interest in the Proteus Consortium. This consortium aims to optimize the use of patient-reported outcomes to ensure that the patient's perspective is effectively captured and can be used to inform research and practice. Proteus has been supported by the Patient-Centered Outcomes Research Institute and Genentech. This is one of a series of presentations about Proteus and the tools and resources available to optimize the use of PROs in clinical trials. There is an introduction to PROs and the consortium. A second presentation introduces the 6 core Proteus tools shown here and their role in guiding the design, conduct, analysis, reporting, and application of PRO clinical data. For those looking for more detail, there are 2 sets of presentations that provide an overview of the recommendations for each of the 6 core Proteus tools. The first set is meant to provide sufficient information for someone who might be reviewing a paper on that uses PROs, but not necessarily applying the recommendations themselves in practice. There is a second set of presentations that provide the level of detail for actually applying the tool's recommendations in practice. This is the 6th of these more detailed presentations in that series. All of the presentations are posted on the Proteus website, that is at the Proteus Consortium.org. In this presentation, we provide a user's guide for clinicians who are reading an article that reports PRO findings and a worked example. This presentation is primarily directed at clinicians who may be familiar with the PRO field and provides a checklist to help them assess the quality of the PRO research studies, and also to potentially use those findings in clinical practice. The article reporting the checklist was published in the Mayo Clinic Proceedings in 2014. I must acknowledge my collaborators, Anna Bradford, Vic Vilanovich, Miriam Sprangers, Michael Brundage, and Claire Snyder. This article was reviewed by members of the International Society for Quality of Life Research, or ISAQOL, and is endorsed by the ISAQOL Board of Directors. So why is this resource needed? To use PRO results to inform patient care, clinicians need to be able to evaluate the published literature that includes PROs. There are, however, many barriers to clinicians actually doing this, to applying PRO findings in clinical practice. These include a lack of familiarity, which stems from mostly a lack of education and training on measurement science and on the interpretation of PROs. There is a wide variety of PRO measures, and it's difficult for a clinician to keep up with all of these. And there's variation in how PRO findings are reported in the literature. The purpose of this resource is to help practicing clinicians apply results of clinical research studies that include PROs and to use them in the care of their patients. By providing a brief checklist to help clinicians review published research studies, we hope to make it easier and more convenient to understand those studies. This paper builds on guidelines published by Guyette et al. in a classic paper in JAMA in 1997. Our paper in the Mayo Clinic proceedings proposes 5 key elements to consider when reading a published study that uses PROs. The elements include assessment strategy and study design, performance of the PRO tool, validity of the results, context of the results, and generalizability to one's own patient population. These questions were formulated into a clinician's checklist to make it easier to address each key element, and we will go over these in turn. The first item was the PRO assessment strategy appropriate. This applies to all clinical research, but we will focus on use of PROs in the trial and whether or not the research strategy was sufficiently rigorous. Was there a hypothesis study stated about the use of the PRO? Was there an a priori hypothesis that explicitly was intended for PROs? Were the PRO measures described? What measures were used? What was the timing of their use? And what was the follow-up of subjects? Was the content of those PROs appropriate? Did the investigators measure aspects of patients' lives that the patients considered to be important? And did the PRO domains used in the study correspond to the anticipated effects of disease and treatment? Were all important aspects of patient-reported outcomes included? This is important to prevent biases from concerns that might have been left out of the analysis. The second item, did they measure PROs effectively? Was there evidence for the reliability and validity of the PROs in the study? Did the PRO instruments work as they should have and were expected to? Was there evidence that they were reliable? That is, was there evidence for internal consistency and or retest reliability? And was construct validity well established? Did the measures behave the way they were intended to? What about missing data? Were missing data handled appropriately? If that is not the case, the results could be extremely misleading. Was a similar number of questionnaires completed by the respondents in all treatment groups at every time point? Was there a missing data management strategy? And was there a data analysis plan for handling death in the event that death was a frequent occurrence in the study? The third item is, should I believe the results? Was there internal validity to the studies? Are the findings established and believable? Is it likely that the observed effects were caused by the intervention? If there were other non-treatment factors that might be likely to affect the PRO outcomes, was there an adequate risk adjustment strategy to control or adjust for those variables? The fourth, were the results placed in clinical context? Was the clinical meaning of the results explained? Was it big enough so that you should care? Was the magnitude of the effect on PROs described? And has it been demonstrated what comprises a clinically important difference? Was the difference or the change in PRO scores, was it big enough that you should care about it? Will the results help me in caring for my patients? There are likely to be both benefits and harms, both clinical and in terms of PROs, Were they recognized and were they reconciled? Might there be potential trade-offs between quality of life and quantity of life, for example, or between the quality of life outcomes and some of the clinical outcomes? And does the paper describe what a clinician should then do with the results? Will the study information help clinicians communicate with patients about treatment options and what the likely outcomes might be in terms of PROs? Are the results from the group that was studied relevant to individual patients? In particular, do the results apply to my patients? Is there enough external validity to your practice? Was the study population similar enough to your patient population that it makes sense to apply it in practice to your patients? Let's go through an example. For illustrative purposes, we apply the Clinicians checklist to a published article to illustrate its use when evaluating a clinical study. In this article published in the BMJ by Mutri et al. In 2007, we look at the paper which examines a randomized controlled trial of a group exercise program for women with early stage breast cancer. In this study, both primary and secondary outcomes were measured using PROs. So let's try to apply the checklist. First item, was the PRO assessment strategy appropriate? Was there a PRO hypothesis stated? From the paper, it is stated 12 weeks of supervised group exercise would improve quality of life for women during treatment for early stage breast cancer. And the benefits would be maintained for 6 months after intervention. Patients were randomized to the intervention, that is the group exercise, or to usual care, no group exercise. From the text, they actually state we tested the hypothesis that 12 weeks of supervised group exercise as an adjunct to usual care would improve quality of life for women during treatment for early stage breast cancer, and that the benefits would be maintained for 6 months after the intervention. So I would say that we could check this box. Continuing with that first item in the checklist, were the PRO measures described? The FACT-G, or FACT General instrument, was presented as the primary outcome measure, and the 4 subscales of the FACT-G were described. Secondary PRO measures were the BDI and the PANS. Other secondary measures included some clinical measures, physical activity and body mass index, performance, a 12-minute walk, and a shoulder mobility test. References were provided for the development and the validation of the FACT scales and the other PRO measures. Measures were described in general terms as appropriate for use with cancer patients. And of course, the FACT was a cancer targeted or a cancer specific measure. Data were collected at baseline, at the end of the intervention, and 6 months later. And these seemed appropriate given the hypothesis and the intervention. So I would say that the answer to this in general would be yes. Was the PRO content appropriate? The outcomes assessed were supported by a brief literature review and seem appropriate to the hypothesis. Item 2 in the checklist, was there evidence presented for the reliability and validity of the PROs? In fact, no data were presented on the reliability of the PRO data from this study. However, there was pretty extensive published data on the reliability and validity of those questionnaires that had been established previously, including in populations similar to this one. Were missing data handled appropriately? There was a flowchart of allocation and assessment. The intervention group did, in fact, have greater loss to follow-up than the control group. Deaths were rare in both groups. There was, however, no specific discussion of an analytic approach to addressing those missing data. So, item 3, should I believe the results? Were the results internally valid? So in this study, the primary hypothesis was not supported. Presentation of the results focused on outcome differences found between the groups assigned to exercise and usual care. There were significant differences with highly significant p-values and trends that were identified in the 12-minute walk and shoulder mobility tests. These are a bit difficult to interpret given the failure to meet the primary endpoints in terms of PROs and the lack of specific hypotheses regarding which particular PRO domains were expected to differ between the groups. How can we know that the differences were not merely by chance? Were the results placed in a clinical context? Was the clinical meaning of the results explained? The authors note that it's difficult to determine what part of the exercise program was associated with benefits, and that participation in the group itself may have been valuable. The findings on shoulder mobility and the walk tests do support physical benefits of the intervention. So will the results help me in caring for my patients? In the author's own words, one weakness is that we don't know which aspect of the group exercise experience provided the most benefit. Our qualitative data suggests that the group itself was an important aspect and that exercise in standard settings did not provide the same benefits. In addition, improvements in the 12-minute walk and shoulder mobility tests that favor the intervention group are more directly attributable to exercise than to the group participation effect. So external validity, do the results apply to my patients? So previous research has established the potential of exercise to improve physical and psychosocial aspects of quality of life in breast cancer survivors during and after treatment. The interpretation is a bit difficult without a statistically significant result on the primary endpoint. However, the authors promote the various positive findings from the study. This study used a group-based exercise program. Generalizability is therefore limited to settings in which group exercise could be implemented. Many participants in the trial were stated to have not been able to attend the classes because of the required commuting time to class, perhaps explaining the missing data. So what would you conclude? It's a little difficult to draw firm conclusions from this paper, but I hope we've demonstrated how to dissect the paper and to help and how this can help you determine whether or not the results are likely to be applicable to your patient practice. To recap, the quality of PRO research studies and their design affects the usefulness of the resulting PRO findings for clinical decision-making. The clinician's checklist can help clinicians to determine whether a PRO study was conducted with sufficient rigor for the results to be believed and applied in practice, and to help evaluate the relevance of PRO findings, in particular for their own specific patients that they have in front of them. So you should check whether PRO results are believable, if PRO endpoints are relevant to the patient population that was studied, if the magnitude of the results are clear. If all of these things apply, then the clinician will be better equipped to apply PRO findings from that study to their practice and patients. For further reading, you can find the articles by Wu et al. And by Gayat. I hope you found this helpful. Thank you.